Underserved in Health today, and I'm speaking with Dr. Chris Reddick, Vice President and Head of U.S. Health Equity, Corporate Social Responsibility, and Philanthropy at Takeda. He's here to talk about Takeda's expanded partnership with Partners in Health and their shared mission of breaking down barriers to healthcare. Thanks for being here today, Dr. Chris.
Thank you, Tamara, for having me.
It's good to have you back virtually. You were here previously for a Q&A, so it's good to have you back kind of face-to-face. All right, let's begin. Please give an overview of the partnership between Takeda and Partners in Health.
So Takeda's partnership with Partners in Health is actually a long one. We've been working and partnering with Partners in Health since 2017 in a global effort to address health inequities. And that's been in the Caribbean and Haiti and sub-Saharan Africa, really all across the world where Partners in Health has their footprint. And the core of that work has been working very closely with communities to understand what their barriers are to connecting to the healthcare system, and then trying to put approaches, programs in place to try to overcome those barriers. So it's as simple as that. Recently, we expanded that long-term partnership to include work here in the U.S. And that will focus initially in the state of Massachusetts. As you may know, there was a recent findings and publications about the burden of health inequities on the state. Over $1.5 billion per year in terms of the cost of these health disparities and inequities. So Partners in Health has really looked to focus on Massachusetts, and we agreed with them to bring the work we've been doing internationally right here to our own backyard in the U.S.
Can you talk about the new health equity communities of practice and what specific systemic barriers to equity they aim to address?
Yeah, this is part of this work with Partners in Health. A big component of that is establishing these communities of practice, or COPs, in the communities. And again, this is something we're taking learnings from the work internationally and bringing that here to communities right in our own backyard. And essentially, what we're doing with Partners in Health is realizing that there are multiple stakeholders in the community that can help overcome health inequities and barriers to people being able to access the healthcare system. But one of the challenges is all those stakeholders traditionally work in their own silos. So whether it's government, nonprofits and NGOs, corporations, community leaders, community-based organizations, CBOs are all doing great work, but it can be a little bit disconnected. So the vision for the communities of practice is that we're building a framework for all of those stakeholders to come together in a community and align on the initiatives that will break down those barriers and improve that access. So it really is an alignment forum for those communities. And that's something that the community actually said they wanted. This was their need. As we're doing good work, we have good ideas, we're all kind of working in silos. Can you help bring us together so we can have more impact? So that's the real kind of focus of these communities of practice.
So the ask came from like the community organizations. Who did the ask?
Yeah, this is listening, Partners in Health. That's part of their models, going into communities, doing a lot of listening, interviewing stakeholders. And a common theme that came out was, I'd love to know a bit more about what other stakeholders are doing in this space so that we can align, we can come together, and we can champion each other's work and kind of co-create. And so Partners in Health came to us and said, hey, this is the need that we're hearing from the community. Can you work with us to bring these to life?
How does Takeda plan to expand the capacity of local health departments and communities to plan and deliver programs focused on health equity and community inclusion?
So I think to expand this, what we're doing coming out of the communities of practice, one key area that has come up is the need for uh, more training and deployment of community health workers in communities. So we've seen that during COVID most recently, that this was a strategy that really worked to help connect, actually raise awareness of diseases in the community, and then connect those who have those diseases to healthcare systems so they can receive treatment. So that's a key part of this partnership is going into communities, understanding what's the current infrastructure around and utilization of community health workers, and looking at how we can expand that. So training more community health workers, expanding their remit. So not only communicable diseases like COVID and flu, which have been traditional roles for community health workers, but expanding that to non-communicable chronic diseases, like cancers, like uh, gastroenterology, other chronic diseases that are impacting our communities, looking at utilizing a broader and expanded role of community health workers to tackle those areas.
What measurable outcomes does Takeda hope to achieve with this partnership in terms of improving health outcomes for communities disproportionately affected by healthcare disparities in Massachusetts?
Yeah, so where we are now in 2024, I think it's really important that all health equity initiatives have that component of impact, right? We've moved from talking about commitments to health equity to really now needing to try pilots and initiatives and measuring whether they are having an impact. And if they do, how do we scale those up across multiple communities, states, and even nationwide? So that's a key piece of not only our partnership with PIH, but with any partnerships we have is the importance of impact measurement. So we have both qualitative and quantitative measures will be part of this, and both short term and long term. So in the short term, we really are looking at things like I'll go back to the community health worker piece of this. We really want to look at measuring how are we expanding the numbers of community health workers, right? So that has a double impact on communities. One, you're identifying people within the community who are trusted intermediaries, trusted leaders in the community. Um, but as they take on community health work, if that can become a permanent job, you're also expanding workforce development in that community. So you have both now a trusted healthcare liaison in the community, and you've also increased employment in the community. So we see that as like a critical factor. So simple measures we'll be looking at around expanding the community health worker um, force in those communities. Then longer term, we want to look at, or I should say in the short term, we want to look at the effectiveness of community health workers in getting people with diseases to the healthcare system, connecting them into the system. So we'll look at things around diagnostic rates, greater numbers of appointments being made at hospitals, and all those follow-ups. So that's the connection. Does it work? If you can expand the community health worker um, force, does it work to actually get more patients connected to the healthcare system? That's kind of in the short term. And then long term, obviously, what I think all good health equity programs is, does that reduce inequities in the care and outcomes of those patients? So we won't know that till down the line of, does having a community health worker um, increase connection to the system? We'll measure that in the short term. but does getting connected to the healthcare system earlier, perhaps in your diagnostic journey, um, help you get better treatment and then have better outcomes on the end. So we're looking at the full patient journey and the full scale of outcomes in that. So stay tuned. We're hoping to communicate results along the way.
I think you're probably going to find, I'm not a clinician, but I think you're probably going to find that the answer is going to be yes, because more people trust people who they interact with and see every day on a community level. Um, I'm curious, Dr. Chris, what did this look like in the background? So you've had this relationship, Takeda's had this relationship with PAH. What prompted you to get together and say, we've got to deal with this locally? Was it the study, the 1.5 billion a year? What started that conversation to do something more local?
Well, I think this conversation, the partnership between Takeda and Partners in Health really evolved from an overlap and a shared vision for how to address health inequities in communities. And so we discovered that again back in 2017, where we feel that in order to make change for communities that are facing inequities, whether it's due to racial and social injustice or where you're located, rural versus city, um, uh, geographies, or any of the hundreds of different areas of inequities and that communities face. We felt like the best way to address that is in the community, working in the community. So not the 50,000-foot trickle down, which is important, right? But for our company, we felt like working with partners that are in the community on a regular basis was
Mhm.
the best way to understand what the real barriers are. So this is not coming from a report or through, some secondary means, but hearing directly from community members about what their lived experience is, what their barriers are. And then hearing that directly, we could co-create with those leaders because I think this is sometimes not highlighted that communities have been dealing with inequities, especially communities of
Yes.
color, have been dealing with inequities for forever.
Oh, yes.
Um, and they've developed solutions, workarounds, have great ideas on how to fix those. Uh, as partners, we can try to um, facilitate those pilots. We can try to help them come to fruition faster. We can help to expand them. But there are great ideas in the communities, great leaders. And so that's part of our philosophy is working with those leaders to address those issues. Partners in Health has been rooted in that model of working within the community in all of their work around the world. So it made kind of a perfect partnership. Our philosophy on how we want to help foster change aligned with Partners in Health's model of being in the community and strengthening the community so that they can um, take care of people in their community long term.
I'll be curious to see how disparities in outcomes changes with this partnership. I'd be curious to see that information. So Takeda and PIH, the relationship, the global partnership dates back to 2017.
Yes.
What key lessons or successes from your global initiatives are being applied to this new community-centered health equity initiative in Massachusetts?
Well, I think we talked about it before, Tamara, that it's really working directly with the community leaders, right? So it's not coming in saying, we have a great idea. This is what you need. We've seen it work in other communities, so we want to bring that to your community and show you something. It's really been in our international programs. help us understand what the needs are and help us understand what you're doing and what your ideas are, and then how can we foster that and strengthen that. So that was the learning that we had there. And for example, in our international work, Partners in Health working with communities, there was a big need. The big gap was um, missing diagnostic centers in communities. So how do we actually know that people in rural settings and underserved settings in places like sub-Saharan Africa or Haiti have diseases when the nearest clinic that has the diagnostic capabilities to test for these complex diseases, whether it's COVID or whether it's a certain type of cancer.
Mhm.
So they asked us to support them in the community and building this diagnostic capacity and building up these centers around the world to help patients get earlier diagnosis without having to travel, many miles to do that. Um, so that was something that we've done internationally as an example. Here in the US, that's not the need, right? So we've actually adapted. We're not taking something that was fit for purpose for one community. The need for diagnostic centers was different here in the US. There are community centers, there are tertiary centers that have these capabilities. People just don't know about them. They don't know how to access the services that we have in the U.S. and in many of our communities. So that's why we're shifting towards community health workers. Again, this has been an approach that's worked ex-U.S. It's been well documented how community health workers can improve health outcomes. That has been um, hit or miss here in the US, the utilization of CHW. So we've seen coming out of COVID that this could really work to, as you talked about earlier, reducing and improving outcomes for patients. So we've adapted that approach from our international work with PIH to here in the US.
So how does the partnership aim to address and or reduce economic burden due to avoidable healthcare spending in communities of color?
I think what we're hoping, we talked about before, just in Massachusetts alone, you have that $1.5 billion of costs due to inequities across the state. So what we're hoping long term is that by connecting uh, communities and patients who don't normally have that connection to the healthcare system, it's complex, it's wrought with barriers along the way, that by doing that earlier, having the community more aware of diseases that are impacting their community, and that'll involve sharing of data, right? Bringing information to the community so that they know what's going on in our community, and then through interventions like community health workers, getting them connected earlier in their kind of disease journey to the healthcare system. We're hoping that that in itself will reduce the burden, the economic burden of treating patients too late, right? It'll also hopefully reduce the burden of hospitalizations, right? Where either patients are going to the emergency room as their source of primary care, or they're waiting too late, they don't seek care at all, and the disease has progressed to a point where it either again results in hospitalization or mortality. So that's what's driving a lot of the spend and the cost uh, in the healthcare system due to these inequities of lack of access to services and to care. We're hoping some of these models, now this will be a measure that we'll have to do down the road. We're hoping that some of these things like communities of building communities of practice and helping communities align all of their efforts by expanding the community health workforce, that these early interventions will pay off in a reduction in those negative outcomes. And that's where the cost savings will come from.
Is the, and if you don't know this, that's okay. I'm just curious. Is the community health workforce, are they using tactics to raise patient awareness to get them into the system sooner? Do you have any knowledge of that, or is it sort of hands off, like, okay, we trust you and do your thing?
Oh, no, I think the community education is a big component of that. And I think we saw with COVID
Mhm.
that that kind of culturally competent, that trusted intermediary talking about um, disease in a way that was accepted, trusted by the community was key, right? You can't get people to engage in the healthcare system if they don't believe that the disease exists or that it's prevalent or they don't understand how important this is. So that trusted communication is key. So they're absolutely doing that in different ways, right? So health workers going door to door. There are community health workers that work in barbershops and hair salons at markets on the weekend, right? So that's the brilliance of the community health worker forces. They're everywhere that the community is because they're part of the community, right? They're at church service
Absolutely.
during the week and on the weekend. So people see them, and once they get trained up with information, they can become that trusted source of education, not only on disease awareness, but on how to access resources like food, employment, other things that are important in social determinants of health, as well as how to access the healthcare system for for their particular disease and for their overall healthcare.
What challenges do you foresee in the implementation of these health equity initiatives, and how does Takeda plan to overcome them to ensure successful outcomes?
I think the biggest challenge um, in this partnership and working with the community is just sustainability. Right. It's making sure that we can keep these efforts in place, keep the communities of practice in place as things are moving and shifting in the community. Um, as we try to broaden the community health workforce, it's that sustainability piece, and that's going to require policy, investment, all of the traditional bricks and mortar that make any kind of initiative sustainable, and that's from all the stakeholders, right? Coming forward with that. So I think those are our biggest challenges in doing any kind of community health work is making sure it's sustainable, um, and then making sure that we can replicate that in other areas once we have success.
Dr. Chris Reddick, thank you so much for your work in health equity. Thank you for being in the fight, and I appreciate your time today.
Yeah, and thank you, Tamara, and thank you to Urban Health Today for all you're doing and getting the word out to our community. So thank you.